Harold Sackeim of the Columbia University College of Physicians and Surgeons. And Professor Sackeim is considered one of the founders of the field of brain stimulation. He was educated at Columbia, University of Oxford, and University of Pennsylvania, and has been on the faculty of Columbia since 1977. Presently is a professor at the Department of Psychiatry and Radiology at Columbia, at the College of Physicians and Surgeons. He served as chief at the Department of Biological Psychiatry at the New York State Psychiatric Institute for 25 years, where he led research programs on ECT. And he radically altered the understanding of both mechanisms and optimal therapeutic practices of this very, until today, very effective treatment. But he's also an inventor of more recent therapeutic modalities in psychiatry, like magnetic seizure therapy and focal electrically administered seizure therapy. He conducted seminal clinical studies on psychiatric applications of TMS and vagus nerve stimulation and DBS. And through the use of brain imaging methods, Dr. Sackeim has contributed to the knowledge of the pathophysiology of major depression, mania, schizophrenia, Lyme disease, and Alzheimer's. He received numerous national and international awards, both for his research contributions, and is the founder editor of Brain Stimulation Basic, Translational, and Clinical Research in Neuromodulation. And among many other things, he's a very close friend of Benny and a close colleague of him. So it's it fits us very well to have Professor Sackeim as the first speaker of this meeting.
Today is a celebration not only of Professor Lerer's 70th birthday, but I can't help but note that this is also the 70th anniversary of the State of Israel. And it's for both reasons, really a great honor and pleasure for me to be here. The other thing I would point out is that both are much younger than ECT. This year is the 80th anniversary of electroconvulsive therapy, and at the end of this talk, I'm going to sort of give you a snapshot of what the future will be next 20 years, and why I think we will hopefully all be together in 20 years, celebrating both Benny's 90th and the 100th anniversary of ECT. It's traditional for an American to disclose their relationships with industry. I've consulted to many brain simulation companies. I should in particular thank the Mekta Corporation for sponsoring my visit to Israel today. I've consulted to many pharmaceutical companies, and as mentioned, I'm the inventor of some new forms of brain stimulation. First, I'm going to begin a little bit, very quickly, on a snapshot, a very quick run through some of Benny's contributions to the field of ECT and then beyond. This is one of Benny's very first papers when he was at Ezrat Nashim, and as you can see, Chaim Bellmaker is the senior author, and they were looking at, in an animal model, the effects of ECS, the animal equivalent of ECT, versus chronic haloperidol administration in their effects on dopamine receptors back in 1981. He was doing state-of-the-art biochemistry, looking at what was very important at the time, clinical issues. I met Benny shortly after this paper appeared. We were introduced by, who is still a mutual friend, Jack Blaine, at a meeting, a clinical meeting in Florida, Key Biscayne, Florida. I forget whether the year was 81, 82, whatever, but we met then, and I had an opportunity to visit Benny at Wayne State University, where he was a research fellow with Sam Gershon. I love Sam Gershon because he's one of the few people in the field of psychiatry that was shorter than me. Absolutely true. I organized for the National Institute of Mental Health and the New York Academy of Sciences in 1985 a conference on ECT. As you can see on the right, a book came out from that. It invited Professor Lerer to this conference, and even though he was really at the beginning stages of his career and the other people we invited were real world luminaries, he was doing some of the most important work at the time, certainly in my opinion. And two things to note in this paper. It was an animal model of ECT-induced amnesia. Animal models have been critical to the development of new procedures, understanding in psychiatry, and have been part and parcel of Benny's work throughout. And there are very, very few people in our field who've extended from the treatment of patients down to working with rats. And Benny has really embodied that. And the other thing I would point out is at the time, the standard view in psychiatry was that the amnestic effects of ECT were all transient. They were not clinically important. They went away. And that controversy has since been resolved, since we and other people have been able to establish that, yes, indeed, ECT can induce permanent memory loss in people. We know that that can happen. In fact, we know how it happens. Benny took on the fact that he could model that in animals, the amnesia produced by ECT in the animal, which was in some way really quite startling at the time. And the other thing that was noted about this work is that he was looking at essentially the acetylcholine system, using really state-of-the-art methods to look at how changes in cholinergic transmission may underlie some of the cognitive effects. The group here in Jerusalem did a series of studies that have become classics in the field of ECT. They're really the only studies in the field of ECT that ask a basic clinical question. Does it matter whether you treat people 3 times a week, as we do in the United States, or twice a week with this treatment? And essentially what Benny's work did and demonstrated was that twice a week treatment got people just as well as 3 times a week with less cognitive effects. That it took a bit longer, but it was softer in terms of its impact on the patient. And essentially the message from that work is Americans are very impatient. That's still true to this day. As the years went by, he was asked as a senior authority to comment on new directions in the field. When the work at Columbia came up with ultra-brief stimulation, which is widely used today in Israel and across the world, he was one of the people to first note the importance of this change in treatment technique. And in his work, as you'll hear more about in the next talk, has extended to the newest forms of brain stimulation. In this case, the use of deep brain stimulation in the subcallosal cingulate area for the treatment of depression. And in this particular study, they're attempting to ask the question whether treating at a low frequency, 25 hertz versus, I forget what your high frequency was, 120 hertz maybe, whether that made a difference in impact on depressive symptoms. Benny's work is extremely broad in its investigation, its application, and its implications. I'm going to just give you 2 more examples. This is a study, a very important clinical study, in which the question was asked: if you add T3, a thyroid hormone, to an antidepressant at the very beginning, do you get a better outcome than if you give the antidepressant alone? A question that really hadn't been addressed well in the field of psychiatry. And this is the definitive study. In fact, it was this study that led to the use of T3 in the STAR-D study and the revival of the use of supplementation with thyroid hormone. I was included as an author on this because Benny flew to my house in New Jersey and had me with yoke and whip do the statistics for this trial. The most cited paper of Benny's is a 2014 paper, just 4 years old, in Nature, which already is almost comparable to STAR-D in the number of references it's received, yet it's only 4 years old. So it will probably be one of the most cited papers in the history of psychiatry.
There's more authors than citations.
For other purposes, I wrote something that Benny will see at some point, reflecting on his career, and one of the things in this note to Benny that I wrote was: our scientific interests have often intersected over these past almost 40 years. Your palette was more diverse than mine, as you use various basic translational and clinical approaches to understand a variety of disorders and improve their care. You cross from depression to schizophrenia to anxiety disorders, delving into animal models, genetics, neuropharmacology, brain imaging, neuropsychology, ECT, DBS, pharmacotherapy, etc. Clearly, keeping kosher didn't inhibit your scientific appetite. I have long admired your deep intellectual commitment and the joy you take in the pursuit of knowledge. We are kindred spirits. However, there's some things you need to know. Benny has also matured over this period of time, particularly in his attire. Here what you see is Benny in 1991, after we had a series of dinners of the ECT world, and Benny here is dressed like a Don from Miami, you know, part of the Miami Mafia, showing up in Italy in 91. Now, here is at my house in the backyard just a few years later, and the guy to his left is Matt Rudorfer. He's runs ECT for the National Institute of Mental Health, the funding for it. And there's Benny. They're competing on who's the worst dressed at this party. Again, in my house, a few years later, in Chappaqua, New York, you see there the guy in the middle is a Frenchman, a psychopharmacologist in New York City. Very, very handsome man. Very just. There's Benny, sort of improving along the way, and I'm drunk. And now we reached the pinnacle. Here we are in London, where they shot the Harry Potter movies, right? And there you see them, Benny aspiring to be an Englishman. I'm now going to shift gears and speak briefly about brain stimulation as a field of inquiry, and then about the future of ECT. Brain stimulation is a new field of therapeutics and a new field of medicine. It is a new discipline. And we won't have time, but I will argue that it presents a fundamental challenge to our psychopharmacologic models of how we treat psychiatric disorders. And I will argue that it will likely replace much of psychopharmacology in the future. So those are pretty bold statements. I'm representing Wilder Penfield here, not only because he was the man who gave us the homunculus by directly stimulating the cortex of patients who are undergoing epilepsy surgery and telling us where the sensory and motor homunculi are, but he was also the individual that demonstrated that with a direct electrical stimulation of brain, we could evoke complex psychological phenomena like complex memories and emotions and so on. I'm just going to illustrate illustrating this, the power of brain stimulation. This is a man with Parkinson's disease. And if I can get this going, in this illustration, this is just a baseline for this individual. And you can see the slowness of the gait. When he turns around, he's unbalanced. It's fairly torturous to watch a typical Parkinson patient. If we now simply turn on his DBS stimulator in the subthalamic nucleus. This is essentially 2 minutes later, just turning on his pacemaking device. Here we go.
Yeah, go ahead and walk back one more time.
Okay. This procedure now has been conducted in over 200,000 individuals with Parkinson's disease, and that's just one of its utilities. I was recently in Vancouver in British Columbia, where we're going to hold the 3rd International Brain Stimulation Conference in February. There's a 5-year waiting list in British Columbia to get this operation. And if you have Parkinson's disease, you don't want to wait 5 years. There are a couple of important points I want to make. We don't have much time, but first point I want to make is that many of our models of how we engage in therapeutics are wrong. We rarely fix what's broken. the traditional psychopharmacology model that there is a deficiency of catecholamines, let's say in depression, or there's an excess of dopamine in schizophrenia, and that we reverse those and that's how we cure these illnesses, simply doesn't apply in many cases. And Parkinson's and DBS is a beautiful, simple illustration. Basically, you don't have Parkinson's disease until 80% of the neurons in the substantia nigra that box right under the pitumen, until 80% of the dopamine-producing neurons are dead. And with the lack of production of dopamine, the pitumen doesn't get the dopamine, so the D2 and D1 receptors don't get energized, and you essentially dysregulate the signal going to the cortex, where you get excessive excitation going to the cortex, which produces the tremor and the bradykinesia that's associated with Parkinson's disease. What's profound about DBS is we do nothing about what's wrong. We don't try to reverse the death of the dopamine neurons. We're not giving dopamine. What we're doing is we're inserting electrodes in the subthalamic nucleus, in this particular example on the right, and we take that nucleus offline. We're stimulating at 120 hertz, bzzz, and what we do is essentially normalize the signal that goes to the cortex by intervening downstream in the circuit, normalizing the communications that are going through this circuit. My view is that most of our psychiatric illnesses reflect circuit abnormalities, and the illnesses themselves are active in changing the circuits, the dynamics of these circuits. That it matters little, in many ways, how the illnesses came to be, because the illnesses themselves change the brain. That whatever the original, let's say, genetic cause or other biological abnormality, the illnesses themselves are dynamic, and that the way we'll be successful in treating these illnesses is by changing the circuit dynamics. The two guys that are most credited for the development of DBS in the subthalamic nucleus are DeLong and Emery for doing the primate work, again the animal model that outlined what the circuitry was, and the neurosurgeon Benabide at the University of Grenoble in France, who was the first to implant in the human. They are likely to get the Nobel Prize. The other just very quick points about this model. What's being represented in the CT is one of two leads, DBS leads, going in the brain. And as you can see here, there are 4 contacts on a classic DBS electrode, which span about 1 centimeter. The subthalamic nucleus is only about 1 centimeter long. And you have an electrode on the left and an electrode on the right, so 8 contacts altogether. In the operating room, you have to empirically determine which 2 contacts to turn on in order to get your anti-Parkinson effect. The patient is awake, there are no pain receptors in the brain, and you determine your therapeutic effect immediately. If you have the wrong contact, you can provoke depression, you can provoke mania. And this is an illustration that, number one, we don't have any roadmap for any individual as to which particular pathway we have to stimulate. That we determine empirically. There are likely wide individual differences, and particularly when we get to diseases like schizophrenia and affective disorders, it's likely that the pathways that are involved will differ significantly from person to person. A real challenge for our field. And so in the absence of mapping and in the context of individual differences, it's likely to be the case that many of our less focal treatments are going to be, at first, much more effective than those that are overly focal, because, again, we don't have the maps. Even if the resolution that we need is at the millimeter level, we don't know for any given individual. I'm going to go back to this. I want to illustrate with another study. This came out in Science last year, an animal study, which I think has profound implications and should worry all of us in terms of the power of brain stimulation, not only to treat diseases, but to change personalities. In this study, the scientists in China, Hulan Hu's lab, is a graduate of Berkeley, developed a behavioral assay. Mice can be reliably ranked in terms of their social dominance. If you put them in a glass tube, 2 mice, one has to push the other one out. right? And some mice always are winners, and some mice are always losers, and you can rank them 1 through 5 in terms of their determination, their drive, their motivation. It's quite clear that the mice don't differ in weight, they don't differ in strength. What they differ in is this psychological construct of resilience and effortful behavior, how long they persevere. Very much sort of like the rat, how long do they swim in a forced swim test? Okay, so we'll look at first here we go. This is without any manipulation, the rank 1 rat versus a rank 3, mouse. And here you see them being pushed out, the rank 3 being pushed out by the rank 1. Now we're going to do something. We're going to stimulate the rank 3. We're turning on brain stimulation for the rank 3, and what you see is the rank 3 will now push out the rank 1. Okay. What did these guys do? They did some brilliant things, but to just summarize 3 things you should know. They first showed that if they shut off specific neurons in the winners, in the dorsal medial prefrontal cortex, the place that neuropsychologists have long suggested may be the part of the brain particularly important in mediating resilience and drive, determination. They, by infecting specific neurons that they had identified using single unit recording, infecting them with a virus that would now express a membrane that had never been expressed in nature, they could then give a drug that would shut those neurons off, and they turned the winners into losers. And when the drug essentially got displaced from the receptor, they went back to being winners. Then, in the next experiment, which I just showed you, they did optogenetics, which you infect the neurons again, now an area, with a virus so that the cell will be excited by light. And what they did is they took the losers, and when they shined a laser on these now light-sensitive neurons, they could turn the losers into winners. Right? And the dose of electricity, dose of lasers that you needed was a function of how many ranks apart the rats were. There was a dose-response effect. Okay, that's all pretty interesting. We can make winners and losers, ... Then what they did, which is probably the most exciting and most worrisome, is they identified the fact that if you gave the animal 6 experiences of winning that were brain stimulation induced, half of the animals became winners for the rest of their lives. So that rank 3 became a rank 1 for the rest of its life after 6 brain stimulation induced winning. And what they determined was a circuit that they had changed in the brain that permanently led to winning, social dominance, which was a thalamic cortical circuit. That's why the title in science was History of Winning Remodels the Thalamo-Prefrontal Cortex Circuits Reinforce Social Dominance. They're claiming, and this is an area, by the way, that we can reach today with techniques like transcranial magnetic stimulation. They're claiming that we can stimulate particular circuits in the brain to fundamentally change whether you're going to get into Harvard, whether you're going to win that battle with the opponent who's in the alternative army. And without doubt, half the armies in the world are looking at this research and asking, can we make better soldiers with these types of techniques? And these obviously raise very important issues for us to consider as a field, because we're no longer talking about treating diseases, but changing the nature of humanity. I'm going to leave, just to give you some taste for where the field of brain stimulation is going. This is from MIT, Boyd's group, claiming in Cell in the last year that they have developed a technique that allows us to do DBS, just like you saw in the PD patient, or like optogenetics in the mouse, that you could do it non-invasively from outside the brain. And I won't go into the physics of it, but it's essentially using a frequency cancellation approach, where you have 2 fields that differ fundamentally in frequencies. One 1,000 hertz, one 1,010 hertz, and the areas where the electrical fields overlap, they cancel out where you get only 10 hertz. The 2 fields are too fast. 1,000 hertz is too fast for the brain to respond to. But 10 hertz is a preferred frequency. So in this experiment, they got individual whiskers in the mouse to wiggle because they were stimulating its representation of the individual whiskers in the brain. They did CFOS in the hippocampus and got particular subfields of the hippocampus engaged. We don't know whether this will scale up to the human, but certainly I suspect over the next several years we will have more and more really bioengineering attempts to do this from the outside without surgery. This is just an example of now how many different forms of brain stimulation are in not just in therapeutic use but also in research use. This is every year growing markedly, and I'll just give you a sense as to partly why I'm so excited by this field. It's obvious that when you're doing brain stimulation, you, for the most part, are doing spatial targeting. You're trying to impact on a particular area of the brain, although you can do neurochemical targeting. There are lots of ways you can target with brain stimulation, but there's always a focality to it, either a spatial focality or a neurochemical focality. So you're always using it as a discovery tool. You can interfere with speech or you can elicit speech, depending on how you stimulate the brain and where. This is an obvious example. You can reveal patterns of connectivity. So even something as small as a transcranial direct current stimulation, which uses a 2 milliamp stimulus, will result in dopamine release in the basal ganglia of humans. Very beautiful PET work. You can modulate functional activity independently in different brain areas. One example I'll give later is in ECT, there's no reason to have a convulsion. That's the propagation of the seizure to the motor strip. That does not contribute in any way to its therapeutic efforts. We are working towards building inhibitory techniques that will prevent propagation to the motor strip. So you'll have excitation, provoke the seizure from one place, and inhibit its spread to another, so that you can certainly limit the impact of seizure provocation. There are many, many examples. In schizophrenia, we'd love to essentially turn down dopamine in the limbic system and turn it up in frontal cortex. You can't do that with pills, but you can do that with brain stimulation. To me, one of the most important, two important aspects are that we can now use responsive stimulation. Here's a very early example. This technology has now been approved by the FDA and is in routine use in the treatment of epilepsy, where we insert a chip onto the surface of the cortex, read the brain electrical activity as to when the patient is about to have a seizure, determine that they're going to have a seizure, and stimulate and stop the seizure from ever happening. This has now moved further and further in time away from the seizure, so that the prodrome of brain electrical activity before the seizure is now being read. The Department of Defense in the US has just given Harvard and other places $30 million to develop this for PTSD. Can we detect the brain changes that are occurring in the PTSD state and impact there? I'm somewhat skeptical about that, but I have pretty strong convictions that we may be able to do the same. Use responsive stimulation to stop hallucinations and to stop panic attacks and other episodic types of events. This is our future. The thing that to me may be most critical is that any persistent behavioral change you get with brain stimulation is an adaptive response of the brain. It's homeopathic. Electricity is totally ephemeral. It has no metabolite. It's gone. Nowadays, with modern ECT, for example, the total time of exposure of the brain to electricity is this, for a full course of treatment, 1/10 of a second. Yet we have the most profound antidepressant that man has. It's not the electricity, it's what happens when you stimulate that matters, and that is an endogenous adaptive response of the brain to stimulation. Contrast that with using artificial molecules that freeze the brain in a state that it's never been before, and freeze it there for extremely long periods of time. Again, we don't have time to get into this, but I've been lecturing around the world on the idea that our models of major depression have radically changed since Benny and I have been in the field. When we came in the field, depression was an episodic disease and the model was much like pneumonia. Today we teach that it's a chronic illness, much like diabetes, or I would say relapsing MS. We've totally changed our models. And we don't discuss why we've changed our models of this illness. My view is that, in part, the pharmacotherapy has created the chronicity. That we often get patients half well and keep them frozen in that state. That we don't allow the spontaneous resolution of episodes. In the pre-ECT, pre-drug days, the average duration of a depressive episode was about 2 years. But nowadays we see many, many patients who are in episode, quote unquote, for 10, 15, 20 years. So this just gives you a flavor for why the field of brain stimulation has engendered such enthusiasm across the world. And just before coming here, I updated a figure on publication rates. These are a number of publications per year for 5 different brain stimulation technologies. And you see TMS, DBS, are up around 1,200 publications a year. Transcranial electrical stimulation, that includes TDCS, there's a bunch of them, is showing now this big increase in SLUB. ECT, in fact, has doubled over this period of time. So there's widespread enthusiasm across the scientific community for these techniques. If these curves did not asymptote, eventually all of science would be brain stimulation, so they obviously have to asymptote. And we may be just at the beginning of that. Okay. A little bit on ECT and its clinical neuroscience. The people who get ECT are the sickest patients that we see for the most part in the depression world, in terms of their symptom severity, their functional disability, and their suicidality. Yet the extent to which they get well, the extent of clinical improvement, the speed at which they get well, and the percent who benefit is superior to any other psychological or biological treatment. I'll just give you one example of that for people who aren't familiar with ECT. This is from one of our studies, which we did at 7 hospitals in New York City. You'll see some more data from that. And these are scores on the SF-36, the Health-Related Quality of Life Index. And so these are about 200,000 normal controls. These are your generic depressed patient. And the white bars are your ECT patients in this particular trial. There are about 350 of them before getting treatment. So their capacity to fill an emotional role in relationships is drastically impaired compared to other depressives. Their social functioning, their vitality, and so on. People come to ECT not just because they're depressed or severely depressed, but basically they stopped working. They often have stopped eating. They have difficulty sleeping. They want to kill themselves. It's overwhelming, the type of illness that they're dealing with. What you see on the right are the same patients, the subgroup who had remitted and stayed well for 6 months. And their scores are fully normalized. This is the equivalent in psychiatry of the laying on of hands. It's the equivalent of what you saw with that PD patient, before and after. If we did videotapes of them, it would be exactly the same type of reaction. Profound impact that you're having on these people's lives. And certainly I think that clinically was what sparked Professor Lerer's interest and certainly mine. From a clinical neuroscience point of view, ECT samples could be in the past studied while medication-free. Wow, you're giving a punctate treatment, only given it a few times, no drugs on board. So if you want to study the neurobiology of depression, this was the ideal sample. The sickest patients who got the most well without drugs, contaminating everything. So from a neuroscience point of view, these were profound. ECT could be spatially targeted. We knew that at the beginning. That if you did left unilateral ECT one day, right unilateral the other day, you could tell as accurately what side of the brain subserved language. This is based on Liz Warrington's work from London, as if you had done the WADA test where you inject in the internal carotid artery sodium amytal and barbiturate one side of the brain and then the other side of the brain. So ECT had tremendous lateralizing value in terms of, and so there obviously were questions like, could you get people well when you gave it just on one side or the other? And then finally, ECT had characteristic cognitive effects. It's a laboratory for the neuropsychology, neurobiology of learning and memory. And again, the field of psychiatry, for the most part, denied that ECT had any persistent effects on memory, even though it was ECT samples that led Larry Squire and others to our major understanding of the different domains of memory. The factors limiting its use have been its cognitive effects, particularly amnesia for events in one's own life. The question as to whether there are high rates of relapse, the financial burden, pills cost a lot less, particularly in the United States, where a course of ECT may cost about $10,000. Oftentimes, the second question patients ask, after they say they still do that, they often ask, well, how does it work? And we often say we don't know. And so that is often limited its use. And of course, most importantly, is the stigma associated with the treatment and the illness. Since Benny and I have been in this field, there has been incredible progress. What I'm representing here is the amount of time it takes somebody after a single treatment to know what their name is, where they are, what year it is, their date of birth, and so on. Basic facts of orientation. In the 80s, the average time it took people getting sine wave bilateral ECT was 8 hours to recover full orientation. 6 hours for unilateral ECT. You can see these are in minutes on the scale, and I've jumped from 2 hours to 5 hours, just so that the actual bars would be about 2 or 3 stories up if we had it continuous. When we introduced titrated brief pulse ECT, it was reduced to 45 minutes for bilateral, 30 minutes for unilateral. With the introduction of ultra brief treatment, we're down to 10 minutes for unilateral as opposed to the 6 hours at the beginning. FEAST, one of the newest forms of magnetic seizure therapy. With FEAST, we know we got it down to about 5 minutes. And we don't know if we gave anesthesia alone how long it would take to achieve full orientation. We're essentially wiping out the disorientation associated with getting a seizure with ECT. To give you an example, in this, a resident did a rotation with me from Mount Sinai Hospital in New York back in the 80s, and what they found is that 56% of patients treated with ECT in that hospital developed cognitive dysfunction severe enough that they had to delay the treatment or stop it. But basically, patients were continuously confused. Organic brain syndromes were common. That's virtually unheard of today. The reason this is important clinically is not just the acute effect, but the best predictor we have as to whether patients are going to lose memory in their own lives is the time it takes to orient following the acute treatment. So that's what we're representing here. On the x-axis and on the y-axis is the amount of amnesia for autobiographical memories. So getting control of the acute confusion should impact on the amnesia. This is a study of that amnesia, that particular type, back in that New York Academy of Sciences volume by Rich Weiner and Larry Squire at the time. And this is pulse unilateral, sine wave unilateral, pulse bilateral, sine wave bilateral. The higher your score, the greater amnesia. So that even then we knew that the type of ECT you gave mattered. This is from the 7 hospital studies in New York. What we found in studying, we had at every hospital in New York City, these 7 hospitals, we had assessors assigned to them who followed the patients. And the hospitals didn't differ at all in efficacy of the treatment. What they differed is the magnitude of the side effects. So on the right, what you're seeing is the autobiographical memory interview short form, the Columbia measure of autobiographical amnesia, and the extent of it immediately post-ECT in the black and in the white 6 months later is a function of what hospital you're in. So it doesn't matter what hospital you go to in terms of whether you get well, but it will matter in terms of how much of your memory you're going to lose. And we were able to demonstrate, there's the AMI SF at the end, that all of those differences, these are detailed neuropsychological testing of the same patients, are attributable to technique. What the psychiatrist did, how they performed the treatment, determined the amount of amnesia that you get in the patient. These types of findings were recently replicated 2 years ago in a huge study out of Ireland demonstrating that brief pulse bilateral resulted in more amnesia than brief pulse unilateral. This is our work introducing ultra-brief stimulation. The amount of inconsistency in memory in normal controls over a month period is about 1 standard deviation. These are standardized units. No different than ultra-brief rate unilateral. This is a 300-item questionnaire. We ask patients questions like, where were you last New Year's Eve? Who were you with? What was the address of your job, the job before last? What was the phone number? What was the last trip you took out of town? So we collect hundreds of facts about a person. We then went to the family members to corroborate those facts. And then retested the people after the treatment. So what you can see is stepwise, depending on how you do ECT again, you can lawfully, regularly impact on the degree of amnesia. And here what we're seeing, these are essentially effect size units. The difference between ultra-brief unilateral and brief pulse bilateral is about twice a large effect size. And these differences persist months later. Meta-analyses have shown the same thing, that ultra-brief makes a huge difference. In the recent study, the PRIDE study by Kellner and company, 240 geriatric patients who got ultra-brief right unilateral, 62% remitted. There's no question that this is a very effective antidepressant treatment that is markedly reduced in terms of its impact on memory. And so these future treatments, MST, FEAST, and so on, should be compared to, and there are three large international trials now going on comparing these new treatments to ultra-brief right unilateral. For the sake of time, I'm quickly going to skip over the question as whether the effects of ECT last. But what this work has, basically the British were the only people to ask how to best treat the ECT patient once they're well. They did that in the 60s, where they did randomized trials of giving antidepressants versus placebo. And essentially their conclusion was that if you give placebo after ECT, 50% of patients will relapse within 6 months. If you give an antidepressant, only 20% will relapse within 6 months. So everybody thought, we don't really have a problem here. Give everybody antidepressants, and they will, we won't have relapse post-ECT. But when the British did those studies in England, ECT was a treatment of first choice. They were not medication-resistant patients. One of the things that always gnawed at me was, how is it that the medications didn't work when before coming to ECT? We get you well with ECT, then we put you back on the same drugs that didn't work, and now they work. We did a series of studies at Columbia. This is one of them from in the archives in 2000, where we tracked for a year our patients getting New York pharmacotherapy, so the pills are coming out of the ears. And what you saw is the non-resistant patients were relapsing at a third of them over the year, and the medication-resistant patients, almost 70% were relapsing over that year. That led to a paper we published in JAMA, actually giving placebo post-ECT and demonstrating in the modern era, you get about an 84% relapse in 6 months if you give placebo post-ECT, not 50%. That nortriptyline alone, 60% relapse, and nortriptyline and lithium reduced it to 39%. This is the most recent meta-analysis that essentially conveys the same point, that there's a secular change. Relapse rates have gone up and up following ECT since the 60s, most likely because the nature of the population coming to ECT is quite different, as we refined to concentrate on medication-resistant patients. And if I put it all together, what I would say is the outcomes with ECT are better than drugs, certainly, and I'll explain that in a second, but they're nothing to write home about. I had the opportunity to be the science advisor to the STAR-D study. STAR-D was the largest trial ever conducted in depression, 4,000 patients who were all treated with the same drug, citalopram. And if they did not benefit in level 1 from citalopram, 36.8% remitted with it. If they didn't get remit with citalopram then, or respond to it, they were randomized to 7 different alternatives at level 2, and if they didn't respond to that, there was a level 3 and a level 4, essentially escalating the intensity of the pharmacotherapy. STAR-D also had a psychotherapy component to it. But the point here is that by level 3, only 14% remit with the third drug, and if you remit, only 35% hold it for a year. So your likelihood of both remitting and holding it by the third drug is less than 5%. It's almost like epilepsy. In epilepsy, if you fail 2 anticonvulsants, you're a candidate for surgery. And that's, we had an editorial recently in JAMA Psychiatry essentially making that point in psychiatry, that oftentimes we go on and on and on for years, administering one antidepressant trial after another, after another, after another, where the data sort of indicate that for most patients, it's a waste of time. In contrast, we expect in this population about a 60% remission rate with ECT. And conservatively, 50% will relapse within a year. That's conservatively, because there are new methods combining both continuation ECT and drugs that may be better than that. But that means that only 30% will hold it for 1 year. That's what I tell ECT patients, that 3 out of 10 basically are going to benefit from it and hold it for a year. That's nothing to write home about. But it's about 6 times better than your chances with drugs. Recent paper in JAMA just a month ago examined out of University of Michigan the cost effectiveness of ECT versus drug psychotherapy, and they concluded offering ECT after 2 failed lines of pharmacotherapy, psychotherapy, is most likely to maximize its health economic value and is concordant with recommendations from national guidelines and ECT specialists. Increasing use of ECT by offering it earlier in the course of treatment-resistant depression could greatly improve outcomes for this difficult-to-treat patient population. I'm going to conclude by sharing with you some ideas as to where this field is going to go over the next 20 years, and share my excitement as to why the oldest treatment really has incredible opportunities for further advancement. What you've seen is we've made huge progress in minimizing the cognitive effects of this treatment, essentially by refining the nature of the electrical stimulation, by attending to principles of brain stimulation, and deep principles of brain stimulation, and making the electrical signal much more physiologic. We have not stopped. An example is the role of current. Basically, the amount of current you apply in an ECT pulse has a fundamental impact on its distribution in the brain. Here what you're seeing is on the left bilateral ECT, bifrontal, right unilateral feast, and on the right is magnetic seizure therapy. And that the current, whether it's 900 milliamps or 200 milliamps, has a profound impact on how deep the current is going to go in the brain. Essentially what happens in ECT is people vary drastically in their seizure threshold. There's a 50-fold range among people in the amount of electricity you need to produce a seizure. And what we do is we give people with high thresholds many more pulses. People have high thresholds because less of the current is entering the brain. It's shunted through the scalp and the skull, essentially. So what the people with high thresholds have a shallower representation of the current. We give them more pulses, and so what we do is we have in the shallower area a denser discharge through the additive effects of more pulses. People with low thresholds, the current goes deeper and it's sparser. We give far fewer pulses. So we're treating high and low threshold patients we're giving very different forms of treatment. And all the other forms of brain stimulation, whether it's DBS, VNS, TMS, and so on, adjust the current that's being administered. ECT will have to move in that direction as well. Where we stimulate, spatial targeting. There are a variety of different approaches to it, using a magnetic field to induce current in brain. A time-varying magnetic field is one way. I proposed that in 1993 and worked for 10 years with the Magstim company to build the first magnetic stimulator that was capable of eliciting seizures in the brain. And the rationale for that is because the scalp and skull are transparent to the magnetic field, you can much more precisely dose and target using magnetic induction as opposed to seizure induction. It turns out, and there's a large international study that NIMH has just funded to test whether MST is an advance on ECT. I'm extremely skeptical, actually, that MST will ever work, because if you look at the far right, the actual fields that you get in brain with magnetic stimulation are too weak in order for me to think that they're really going to be very helpful. Most people doing magnetic stimulation have been stimulating over the motor strip because it's much easier to get a seizure by triggering from the motor strip, which has the lowest seizure threshold in the cortex, than triggering it from the areas we really want to target. So it's an electrical engineering problem that's in the way of magnetic seizure therapy. You can't get enough oomph in the brain. You can get enough oomph in the brain by treating with electrically, and we've developed new forms. This was inspired by the work of Vahi Amassian, one of the great neurophysiologists. where we've turned ECT to where the current only flows in one direction. We have asymmetric sizes of electrodes, novel electrode placement. This is all in the goal of targeting specific prefrontal structures, orbital frontal structures, as a site of seizure initiation. The work at Columbia for many years has argued that it's where the seizure starts that's critically important, not where it propagates to, because you get surround inhibition, where the brain is trying to shut the seizure off. And it's like a broken pipe in your kitchen that's going into your bedroom and into your living room. You want to shut it off in the kitchen. And that's what the brain does. It surrounds the inhibition there. And so can we choose essentially the site of seizure initiation and then block the propagation? Conquering individual differences. Everybody has holes in their head. We all do. They're called fissures and sutures within our skull. When we apply ECT, the distribution occurring in the brain differs from person to person. We should be in a position not too far from now where we use the computer modeling. Here, this is based on one person's MRI. But when we person by person, now we're in the business of collecting this on thousands of people and figuring out, given the individual differences in where the current is flowing, can we identify what areas of the brain we really need to target, what areas of the brain we need to protect. And we will ultimately be in a position where a high-resolution MRI will be done before this type of treatment. And the positioning of the electrodes, their geometry, and so on will be determined by each individual's MRI. I've already mentioned that another possibility will be blocking the convulsion. And we'll have, instead of the Journal of Convulsive Therapy, the Journal of Non-Convulsive Therapy. Once we block the convulsion, there's no need for anesthesia or muscle relaxation. In ECT, we paralyze the body to prevent fractures because of the convulsion, and we give an anesthetic because we paralyze the body. When you elicit seizures from prefrontal cortex, you get immediate unconsciousness. So the person is not awake during this, and if it doesn't propagate to the motor cortex, there's no convulsion, you don't need anesthesia anymore. So it changes the whole procedure. In terms of the progress in clinical implications, clinical disorders, very fascinating work now going on in kids with autism who are scratching their eyes out, who are physically abusing their siblings, and where people are conceiving of much of this behavior as excited forms of catatonia and are using ECT to treat these autistic children to great effect. I recently wrote a foreword for a book from a mother whose kid was about to be institutionalized, who now is 3 years living at home because the child has received ECT and is no longer essentially gouging their own eyes out. Great interest in treatment-resistant psychotic disorders, and we don't have time to get into it, but there's emerging interest in the use of ECT in PTSD, in part because of the concept of reconsolidation in neuroscience, that basically our long-term memories are distributed across the cortex, but when we re-experience something, they are bound together again in the hippocampus, and during that period of re-experiencing, they're vulnerable to intervention. We want to see for the first time, can we knock out a particular specific memory for a person by having them re-experiencing it just before the administration of ECT? And that's ongoing work that's being done in the Veterans Administration's hospital in the US. Now finally, the last thing I'll end with is ECT has been tied to seizure mechanisms. It was wrongly called convulsive therapy because the convulsion was irrelevant. It is a form of seizure therapy. But ECT is really the only treatment we have in psychiatry where we give a powerful electrical stimulus in an acute single train. The only thing remotely comparable is TDCS that uses extremely low currents, 1 to 4 milliamps, yet it can result in significant neurobiological change. Far more intense. In ECT, we're using about an amp. So about, 500 times the amount that we're using in TDCS. Far more intense stimulus. And I'm just going to illustrate this point as to why seizures are often irrelevant to the biological effects of these strong electrical stimuli. This is work from Antonius Ziss, who was the chairman of psychiatry at University of British Columbia a while ago. And at the left, what you see is ECS being given in microdialysis in the striatum measuring dopamine release. And then if you turn the dial up of the sine wave device, you see that in the filled circles at the top, you get a bigger release of dopamine. You give more electricity, you get a bigger release. But what's critical about this work is on the right, if you give floral ether, which is inhalant convulsive, produces a profound seizure, you get no dopamine release. If you give the electricity and block the seizure with a barbiturate, you get the same dopamine release. The seizure is irrelevant to the dopamine release. And I've used that clinically in treating PD patients. Stan Fond, the guy of Parkinson's disease, head of the Parkinson Foundation, used to send us 20 to 30 Parkinson patients a year to treat with ECT because they became psychotic on the dopamine agonists. And you couldn't give them antipsychotics because it would make their Parkinson's worse. So we treated them with ECT. And it was very clear, working with this, that where you set the dial in the machine determined the anti-Parkinsonian effect of the ECT. So we can begin to think we cannot as a field give up strong electrical stimulation we will have a new field of stimulation-induced pharmacology. We will change brain chemistry at will based on stimulation paradigms. So the accomplishments of ECT over this time that Benny and I have been in this field have been quite extraordinary. The efficacy of the most effective treatment in psychiatry has been preserved, while its adverse effects have been virtually eliminated. We have now effective strategies for relapse prevention that are well established. The probability of sustained benefit is higher with ECT than with any other treatment for the resistant patient. ECT has superior cost-benefit relative to alternatives. We also, I haven't gone into in this talk, made tremendous progress in our understanding of mechanisms of action of this treatment, with wholly new theories as to what may underlie its therapeutic effects. And I think, as you've seen, there are remarkable opportunities for further advancing the practice of ECT. So with that, I do think we will be here in 20 years. How many treatments do we have in medicine that have lasted 100 years? There's very good reason why ECT has lasted this long, this relic of the past, whereas all the other is obviously because of its efficacy. And so there you see Benny through his various phases of development, and I all hope that we will be here together again for Benny's 90th.
We have time for questions, so please.
I'll set the ball rolling. Your statement about inhibiting the convulsion was intriguing, but I recall, and I'm sure you do, the paper by Otterson, in which he showed that inhibiting the convulsion in patients being treated with ECT also inhibited the therapeutic effect. So how does this align with what you said about inhibiting the convulsion?
Yeah, what Jean-Otto Otterson did was not actually didn't have any impact really on the convulsion. What he did was he gave lidocaine, which altered the seizure threshold. So dose relative to threshold change, he changed the expression of the seizure. Nobody, as far as I know, has ever gone. For instance, if you take a monkey and put GABA across the motor strip, you can produce a full convulsion, a mammoth convulsion in the monkey, but there would be not convulsion, a mammoth seizure in the monkey, all over the brain, generalized, but have no convulsion, no bodily movement. That's all I'm saying is that if we take this strip right here and inhibit it, we get rid of the convulsive movements, and boy, would that be a benefit for this treatment, because nobody believes that engaging the motor strip in this type of activity has any therapeutic relevance. So
then why the emphasis on precisely timing the seizure and the peripheral manifestation of the seizure, and then increasing dose in order to increase the length of the seizure?
The duration of the seizure in ECT, I think, is irrelevant for efficacy. In fact, when you turn the dial up and you give a more potent treatment, you shorten the seizure. seizures often get shorter. So you get your longest seizures when you're just above the threshold. They're very low in amplitude. They have very indistinct endings. And then when you turn it up, you marshal that inhibition to shut it off much more quickly. You get a more robust seizure, a larger spike and wave. And the American Psychiatric Association, we had to sort of give a number of what is the minimum time to know that you had what might be an adequate treatment. And that number has now moved. It used to be 25 seconds and 20 seconds. Now it's 15 seconds. It's just to guarantee that the person had a treatment that's likely to be effective. But the whole question as to what about seizure morphology is related to efficacy is a area of great interest in research. Just to tell you, my own group takes a iconoclastic view of this, that I think the seizure is, and ECT is very much like a stress test of the brain. That when we go to a cardiologist and get a stress test of our heart, that's a fact about us. I think that people who have more robust seizures and that end in bioelectric silence are the people who tend to get well no matter how you treat them. So that the seizure morphology is more diagnostic of whether you're having a person who can benefit from the treatment than something that tells you about how to perform the treatment.
Okay. Thank you for your very nice talk. So taking what you said about the medications freezing the minds of patients, would you advise washing patients, resistant patients out, washing them out of their antidepressants, then administering acute ECT, and then continuing with maintenance ECT without ever bringing them back to medications?
No. I think we have to have theoretical contradictions in order to be good clinicians. There's no doubt in my mind that relapse after ECT is less if you get, for instance, both continuation ECT and drugs, and if you get one or the other alone. That all the evidence is pointing that way, that the drugs do help. I think it doesn't make sense to keep people only on the drugs that they failed to begin with. It certainly doesn't make sense just to keep them on an antidepressant. I think that lithium, in fact, the work from here in Benny's group has long been a champion of the use of lithium in this post-ECT period. I think lithium is really key here. But when I see patients, I recommend that relapse is such a profound disruption in life, and there can be so many issues with it, that you want to do everything you can to help the person from preventing relapse. And I recommend both.
First question, please.
Hi. Thanks for your very inspiring lecture. Second, about predictors. We're talking about predictors of response in medication, like pharmacogenomics, and predictors of response, both ECT and both cognitive side effects. Because, can you tell us a little bit about it?
Sure. With regard to ECT, we have some established predictors. Probably the two most important in terms of cognitive side effects are age and cognitive status coming in. So that cognitive vulnerability is increased with age. It's a very interesting relationship because older patients subjectively report fewer cognitive effects of ECT than younger patients, yet objectively they show more. So and we see that with aging generally. So that if you do something like a Beck depression inventory, older patients underreport depression symptoms relative to younger patients. So age is a factor, and patients with pre-existing cognitive impairment, for instance, even something as crude as an MMS, predicts the extent of memory, retrograde amnesia. The same study that showed that orientation recovery predicted amnesia also showed that pre-existing cognitive impairment predicted it. And both effects have recently been replicated by Colleen Liu's group in Australia. So that's a little bit about who to watch out for. Interestingly, if you look at premorbid IQ, people who are smarter coming in complain more afterwards, but have less effect. So they're much more sensitized to anything that is done, but the actual objective effect is less. They have more cognitive reserve. With regard to the predictors of who benefits from ECT. Again, this is very surprising, but over half of the trials have looked at it. Age is a positive predictor. We have very few examples in medicine where the older patient benefits more from a therapeutic than a younger patient. And it's a really intriguing question. What's going on in the older patient's pathophysiology that makes them so receptive to ECT? Psychotic depression is another positive predictor. Patients who present with psychosis are particularly likely to benefit from the treatment. My own view is that's because of the last predictor, which is degree of medication resistance. We published years ago that only 4% of patients with psychotic depression who come to ECT have failed an adequate medication trial, largely because adequate medication trials, the amount of antipsychotic that you need, the threshold is so high that very few patients ever get one before coming to ECT. That's now, in more recent work, up to 25% will have had an adequate medication trial before coming to ECT. So my own view is that, and we have much more data indicating that medication, the degree of medication resistance does predict ECT outcome, where the more resistant patients fare less well. But even among them, they do much better than the alternatives.